Hello, welcome to Casualty Connect, our video series at the intersection between AI and the property and casualty insurance industry. I am Frank Giaoui, the founder and CEO of Optimalex. With me today is Steven Rosenfeld. Hi, Steve.
Hello, Frank. Nice to see you.
Nice to see you too. And you are, or you were a member of the board of OMIC for 15 years, also vice chair of their board and chair of their claims committee. You are today sitting on the advisory board of Optimalex and lead medical advisor. So the subject for our discussion today, Steve, is fact-based decision making in medical professional liability. So, can you tell us why fact-based decision-making is an important subject in general, but more particularly for the medical professional liability?
Well, thank you. I appreciate the opportunity to speak and share my views and thoughts today about AI and medical malpractice insurance. As physicians, we pride ourselves on always making fact-based decisions in all aspects of our medical practice. That we read and critically review the medical literature whenever there's a new drug comes out, whenever there's a new surgical procedure that comes out to be sure that it's safe and effective. And even with new drugs, we often yearn to see studies that compare new drugs to legacy drugs. So often these pharmaceutical companies tell us about the new drug without comparing it to what is already out there. But we're very savvy when it comes to that, and rightly so, because I think that's why most physicians pride themselves on the quality of care they give. And the body of medical literature and medical science is changing from when we were training in medical school or as residents. And you have to critically review every year new things that come along. Some things are worth adopting, some things need to be discarded. And it makes sense. It's a very rational corollary that when it comes to medical professional liability, that it really merits the same fact-based decision making that we currently use in our own individual practices. And currently, there are many MPL carriers and individual physicians who tend to make very emotional or sometimes even poorly informed decisions about medical malpractice issues. It has to do with the fact that sometimes clinical advice and education we received when we were training has changed, and not every doctor keeps up with the latest developments. It has to do with the fact that even risk management recommendations we may have been taught as residents or from prior medical malpractice insurance carriers, that has changed. It's no longer accurate or as helpful. Um, and even the using intelligent data analysis in determining whether or not a medical malpractice claim has merit and should be defended, we need the use of some more fact-based decision making.
Okay. So this is where AI comes in, right? You have, as an ophthalmologist practitioner, the experience of using AI in ophthalmology. Maybe you can tell us a little bit more of that. And then let's make a bridge to the use of AI in the MPL itself.
Thank you. Well, we have been using AI in ophthalmology now for several years. We've been using it for the interpretation of fundus photos, photos of the retina, the optic nerve, the inside of the eye, using it to look for things like diabetic retinopathy, diabetic disease. Systemic hypertension can cause hypertensive retinopathy. And there's even a disease in children called ROP, retinopathy of prematurity, which is retinal damage that children sustain if they're born prematurely and are exposed to very high oxygen in the neonatal ICU. And you can have photos taken, interpreted with AI, and interpreted usually remotely to try and help. There's also AI now being used, and I wear a different hat as a consultant to Modernizing Medicine, an EHR company, in the interest of full disclosure. But we've been leading the way in the use of AI in electronic medical records. And now we're using it in a beta testing fashion. When you first speak to a patient and interview the patient at their visit, you obtain their history and what's called their chief complaint. And then you have to usually either turn to your computer and start typing, or in the case of Modernizing Medicine, you're still using an iPad and you're either typing things or you're just hitting certain buttons. But what this AI can do is it can synthesize and take your whole, 5-minute conversation with the patient and distill it down to what the chief complaint is and some important symptoms. And then the next step will be that it will take those symptoms, tell you what the so-called differential diagnosis is, what the list of possible conditions are that might be causing the problem. It can even then go and tell you what is the leading diagnosis. And if that's your leading diagnosis, it will suggest certain testing that can be done or how you should approach and either treat or get further testing on the patient, an additional workup. And they're even also using EHR now, experimenting with AI as they are doing in the commercial venue, of using it for appointment making and other things where you don't necessarily need to have a human being supervising that, but it's a little different than just going online and trying to push the buttons yourself.
Okay. Okay.
So
So
we're training us to using AI already in our practice.
wide range, and by the way, not only in ophthalmology, in radiology also, and many other fields of the medical practice. Now, how does that relate for the use of AI in MPL?
Well, it has many applications, and one of the things in a medical in MPL, when there's a new claim, there's voluminous amounts of material that come in that are obtained by the medical malpractice carrier, and it's office records from the patient, it's office records from other treating physicians or other physicians that may have given second opinions. It's getting imaging data. And it can be very time consuming just downloading these things and then processing these things. And Optimalex is able to use artificial intelligence to be better informed, to make more timely decisions in the MPL because it's able to condense everything down and help summarize it for us. And as many of you know, artificial intelligence can do this in a very rapid fashion, a very clear and concise way, a reliable and reproducible way, and help us dealing with the cases as they progress. And it can help with risk management, with underwriting, with the claims, and even with the legal process and suit settlement.
For sure. So again, a wide range of application of AI in the MPL, different departments of the MPL. Now, as the chair of the claims committee for many years at OMIC, maybe we should focus more particularly on the use of AI in claims. What is today, and how did you experience the assistance of AI for claims?
Well, it's been very helpful because, again, many times as physicians, you get experience, you have a sort of clinical gut feeling, a clinical gestalt, but you really have to analyze the data and see if what you think emotionally is right is truly backed up by the data, by analyzing this large amount of claims data. And we've learned many things along the way in our claims committee. We've learned things that cases, the longer a case takes, the more likely you are not to succeed in defending that case, and also the more likely to have a costly settlement or jury award in that case. And we found that 9 months at OMIC seems to be a critical threshold, that cases that take more than 9 months to be processed are more likely to result in greater costs defending the case, which makes sense empirically, but also greater risk of a large settlement or award. We've learned that certain judicial venues are less physician friendly. They sometimes we refer to them as judicial hellholes, or places where we know they're not sensitive, and in fact they're sensitive to the plaintiff, not to physicians. They're more likely to have trials that where the jury will make a decision in favor of the plaintiff, of the insured, not the physician, and that they're also then many times more likely to have these large verdicts, or the so-called nuclear verdicts, that with what we call social inflation, which is a trend throughout the MPL industry, and it's not ophthalmology is not immune from that, but you need to be aware of that the severity of claims is increasing. We've also learned that certain medical procedures, or ophthalmologic procedures in particular, are more likely to result in medical malpractice claims, that certain postoperative complications are accepted and known complications of surgery and are easily defensible, but certain other complications are less common and more difficult to defend. We've learned as well with the benefit of Optimalex and their AI analysis that how we handle a dissatisfied patient can have profound effects on the outcome of a case, a medical malpractice case. And that is sort of a multifaceted problem. We've learned that giving an apology to a patient, that was something when I started training many decades ago, we were told never apologize to a patient because it'll come back to haunt you at trial, that it's admitting your guilt. And when it turns out that in retrospect, with decades of data analysis using AI, we've learned that actually if you apologize to a patient and just say you're sorry things didn't work out the way we both had planned and had we and anticipated, that empathy goes a long way to diffusing a situation and doesn't come back to haunt you because as a human being, you feel empathetic and sorry that there's a patient who's disappointed. And that even just being transparent and having open communication with patients is really very good at diffusing a situation because many times when the plaintiffs are interviewed either before a case or many times after a trial, they say if the physician only would have shared with me what went wrong and what, and apologized, that it would have been much different. But many times they're left out in the cold, and it just exacerbates the situation.
So you
And
are this, yeah, go ahead, go ahead.
no, and the last thing that Optimalex has with Agatha, their software, that they're able to generate a summary report and a claims risk score based on how they analyze the particular medical malpractice claim. And they rate it on an alphabetical level from A through F, with A being the most favorable and most likely to be successfully defended, to F meaning you should consider settlement and that it has a very high likelihood of being a much larger verdict in a more difficult case. And so that there's something that they are able to then summarize by taking all this data and analyzing it properly. It gives us more, we feel more confident in the decision that we make or the recommendation we make to our insured that whether they should be settling or defending a case.
So, Stephen, you gave and share many examples where AI is enhancing fact-based decision making in MPL, not replacing the human judgment, but supporting it, either because there is a convergence of analysis and that is even stronger human judgment, or sometimes there is discrepancy in the analysis and it can give a second chance for a further analysis. Now, my question is more for the future. Um, what speed of implementation of AI, considering both the advantages that we described, but also some reluctance, human reluctance, sometimes very legitimate, about the risk. Shall my job will be replaced, or maybe increased liability for a doctor? How do you see this evolving in general, and particularly in the MPL industry?
Well, that's the $64,000 question, and I think that it's to the uninitiated, the knee-jerk reflex, the response is always, well, it's going to replace a lot of lower level workers or lose jobs, and that there are going to be decisions made in patient care or in defending a medical malpractice claim. And if it's bad data in, and the AI then comes out with a bad um, summary of and assessment of whether the case should be defended, that there might be liability. On the other hand, the way we like to look at it is that it is one more way of analyzing a case. That in so-called you have a scale and you're adding weights to the scale until something might tip the balance. And like everything else we do in medicine, when you get data with imaging or blood tests or exams of a patient, it's still up to the clinical acumen and experience of the physician. Sometimes how they treat a patient would be the same thing. It's just one more bit of data to take into account about how we handle a medical malpractice claim and whether we settle, whether we defend, and how adamant we are in going forward. But it remains to be seen. But I think that there'll always be a need for people to be getting the data available, to be reviewing what has been processed. And there's no question that no one yet is relying solely on the analysis of AI without reviewing what went in and how sort of the decision was reached. So it's a great technology providing it's properly harnessed and supervised.
Thank you. That was Dr. Steven Rosenfeld, former member of the board of OMIC and chair of the claims committee, and today sitting in the advisory board of Optimalex as a lead medical advisor. Thank you very much, and we'll see you at the next video series of Casualty Connect. Bye bye.
Bye bye. Thank you.